Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome to the Radiology Review podcast. On this episode, per listener request, let's continue our discussion of arthritis by covering musculoskeletal manifestations of rheumatoid arthritis. On the last episode, I covered key details of psoriatic arthritis and ankylosing spondylitis. So go ahead and check that episode out if you haven't yet listened to the episode and could benefit from more questions and answers about arthritis. As I've mentioned previously, you can follow at RadRevPodcast on Twitter or Instagram to find my latest tweets and posts that currently include near daily high-yield facts for the physics portion of radiology board exams. I will also make a study guide reviewing the information about MSK manifestations of rheumatoid arthritis available for free download on my website, www.theradiologyreview.com. Check out that free downloadable study guide if you are interested. Without further ado, let's get into the questions and answers for this episode. First question: what is the classic distribution of disease for rheumatoid arthritis? Rheumatoid arthritis is classically bilateral and symmetric with a proximal distribution and polyarticular involvement. Uniform bilateral symmetric joint space narrowing with marginal erosions are classic. Note that hand and wrist involvement is essentially universally present with rheumatoid arthritis, including involvement of the proximal interphalangeal and metacarpophalangeal joints. Erosive changes of the triquetrum and uniform radiocarpal joint narrowing are common and are considered an indicator of an inflammatory arthropathy, such as rheumatoid arthritis. Ulnar styloid process involvement may also be seen. Unlike erosive osteoarthritis, rheumatoid arthritis spares the distal interphalangeal joints. Next question: what are key radiographic manifestations of rheumatoid arthritis? Key radiographic manifestations of rheumatoid arthritis include symmetric, uniform joint space narrowing, marginal erosions, most classic at the radial aspect of the metacarpophalangeal joints, juxta-articular or generalized osteoporosis, and periarticular fusiform soft tissue swelling. Later in disease, imaging findings can include things like ulnar deviation at the metacarpophalangeal joints, classic boutonniere and swan neck deformities. Go ahead and look up images of those if you do not know what those look like, because the boutonniere and swan neck deformities seen with rheumatoid arthritis are commonly tested. Additional findings can include subchondral cyst formation, scapholunate dissociation, and, similar to psoriatic arthritis, a pencil in cup deformity. Ulnar styloid process erosions may be seen with rheumatoid arthritis due to extensor carpi ulnaris tenosynovitis. Outside of the hands, classic radiographic features of rheumatoid arthritis include feet involvement with proximal joint involvement, most characteristically involving the fourth and fifth metatarsophalangeal and proximal interphalangeal joints. Remember with rheumatoid arthritis that a proximal predominant distribution is classic. In addition, distal clavicular erosions can be seen with rheumatoid arthritis, and the high riding shoulder sign can also be seen due to subacromial subdeltoid bursitis. That is a lot of information there. It may be helpful for some of you to review that in written form. If you think that would help you, go ahead and access the study guide where you can find the key topics discussed in this episode in written question and answer form at theradiologyreview.com. Next question: what are classic risk factors for development of rheumatoid arthritis? Rheumatoid arthritis is more common in females compared to males. Rheumatoid arthritis is also more common in smokers. Obesity is also considered a risk factor for development of rheumatoid arthritis. Next, what is the classic triad associated with Felty syndrome? That is F-E-L-T-Y, Felty syndrome. The classic triad of Felty syndrome includes rheumatoid arthritis, splenomegaly, and leukopenia. Knowing the associations for things like Felty syndrome is high yield, and these are highly tested concepts. So again, Felty syndrome is rheumatoid arthritis, splenomegaly, and leukopenia in terms of the classic Felty syndrome triad. Next question, true or false? Rheumatoid arthritis is associated with new bone formation on imaging. The answer here is false. Rheumatoid arthritis classically does not have new bone formation to include things like bone proliferative changes. This is an important distinction that can help separate rheumatoid arthritis from other entities to include psoriatic arthritis that is associated with new bone formation. Next question, true or false? Rheumatoid arthritis is associated with osteoporosis. The answer here is true. In the earlier stages of rheumatoid arthritis, you may see periarticular osteoporosis, where you have loss of bone mineral density around the affected joints, meaning the joints that are affected by rheumatoid arthritis. As the disease progresses and time goes on, that periarticular osteoporosis can become more generalized. It is important to remember that osteoporosis is one thing that can help differentiate musculoskeletal findings of rheumatoid arthritis from another process. Next, what are classic imaging features of rheumatoid arthritis in the lower extremities? First, let's discuss the hip. With the hip, you classically would see axial narrowing with possible acetabular protrusion. Importantly, you would not expect to see osteophyte formation, as new bone formation is not a classic feature of rheumatoid arthritis. You also would not expect to see subchondral sclerosis. Note that osteoarthritis has superior hip narrowing, and rheumatoid arthritis has axial narrowing. The difference here is important. Axial narrowing is described as concentric joint space loss with acetabular protrusion, whereas superior narrowing is selective joint space narrowing at the superior aspect of the joint. In terms of the knee, with rheumatoid arthritis, you can classically see tricompartmental joint space narrowing with no bone proliferative changes or osteophyte formation and no subchondral sclerosis. In the feet, there are many classic features, a few of which can include calcaneal erosions with retrocalcaneal bursitis, and erosions that most classically would involve, first, the lateral aspect of the fourth and fifth distal metatarsophalangeal joints. Again, a proximal predominant process wherein the feet involvement can include metatarsophalangeal joints, and corresponding hand involvement can involve metacarpophalangeal joints. Next question. What are classic imaging features of rheumatoid arthritis in the spine? Cervical spine involvement in rheumatoid arthritis can have classic features such as atlantoaxial subluxation and erosion of the dens. Other findings can include spinous process erosions and erosion and fusion of the facet and uncovertebral joints. Next question. Besides rheumatoid arthritis, what are some other arthritic processes that can present with a metacarpophalangeal joint predominant pattern? Other arthritic processes that can prominently involve the metacarpophalangeal joint include things like pyrophosphate arthropathy, hemochromatosis, and juvenile idiopathic arthritis. So important to remember that rheumatoid arthritis is not the only process at play that can involve the metacarpophalangeal joints, and you need to look for additional history and imaging findings to help you correctly identify a case of rheumatoid arthritis on radiology board exams. Next, true or false? Iliopsoas bursitis can result from rheumatoid arthritis. The answer here is true. 3 classic causes of iliopsoas bursitis include overuse injuries, rheumatoid arthritis, and acute trauma. Remember that musculoskeletal findings of rheumatoid arthritis include involvement of synovial joints and tissue, tendons, and bursae. Next question. Besides bone abnormalities that we have already discussed, what additional features of rheumatoid arthritis of the joints can be seen on MRI? Another way to phrase this question is, what are extraosseous findings of the joint in rheumatoid arthritis that can manifest on MRI? On MRI, extraosseous findings of rheumatoid arthritis involving the joint can include things like joint effusion, synovial hyperemia and hyperplasia, with so-called Rice bodies, which are intra-articular loose bodies, Rice bodies, R-I-C-E, which are intra-articular loose bodies. MRI may also show you cartilage loss, subchondral cyst formation, and pannus, P-A-N-N-U-S, formation, which is formation of so-called pannus tissue, which is an inflammatory thickening and excessive proliferation of joint synovial tissue that can infiltrate a joint space. Those are important imaging findings to be aware of, and I would recommend that you go ahead and look up images of some of these so you are prepared to answer questions on not only the osseous imaging findings of rheumatoid arthritis, but also the extraosseous findings in and surround the joint that can also be seen with rheumatoid arthritis. Finally, let's talk about a few things in terms of key features that can help differentiate rheumatoid arthritis from other arthritic processes. First, what are key features that can help you differentiate between rheumatoid arthritis and degenerative osteoarthritis? Unlike rheumatoid arthritis, with degenerative osteoarthritis, you should have distal interphalangeal joint involvement. You classically have distal interphalangeal joint involvement with osteophyte formation, and you classically would not have erosions. Next, what are key features to help differentiate between rheumatoid arthritis and psoriatic arthritis? Unlike rheumatoid arthritis, with psoriatic arthritis, you will have bone proliferative changes, as well as a PIP and DIP predominant distribution in classic cases. Both rheumatoid arthritis and psoriatic arthritis can have erosions, and both can also have a penicillin cup deformity appearance. So again, some key features to look for with psoriatic arthritis are the bone proliferative changes and a PIP and DIP predominant distribution, whereas rheumatoid arthritis does not have classic bone proliferative changes and has a PIP and MCP predominant distribution. Next, rheumatoid arthritis versus erosive osteoarthritis. Unlike rheumatoid arthritis, with erosive osteoarthritis, you have distal interphalangeal and proximal interphalangeal predominant distribution with a classic history of acute onset in a postmenopausal woman and central rather than peripheral predominant erosions. I believe I have described those erosions of erosive osteoarthritis on prior episodes as gull wing erosions. And if you do not know what those look like, please look them up. Last and final question. what are key features that can help differentiate between rheumatoid arthritis and calcium pyrophosphate dihydrate arthropathy, which is shortened CPPD arthropathy. Unlike rheumatoid arthritis, you can have osteophytes with CPPD arthropathy, and you have classic imaging findings of chondrocalcinosis and do not expect erosions in the setting of CPPD arthropathy. That is a fairly rapid review running through these questions and answers on the musculoskeletal manifestations of rheumatoid arthritis. If helpful for you, go ahead and download the free study guide at theradiologyreview.com. Thank you for listening to this episode. I hope this is helpful for many of you. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.